Welcome, everyone, to the Center for Infectious Disease Research and Policy Antimicrobial Resistant Project webinar series. We're coming to you today in an important week, World Antibiotic Awareness Week, also known as World AMR Awareness Week. It's an important week for those of us that work in the space of increasing public awareness and professional awareness around AMR. The topic that we're talking about today is cancer and AMR, and this is an important topic. It's a roundtable discussion, and we are pleased today to have authors of two very important publications over the past year, as well as a panelist from the CDC. We're going to spend 60 minutes in a roundtable discussion, discussing these recent publications on the impact of AMR on cancer patients. Our panelists will discuss their learnings from the publications and implications to their work. The panelists will also share their experiences in the space of stewardship, infection preventions, and their efforts to curb and reduce antimicrobial resistance. So before we begin, I need to introduce these esteemed people. So if they'd like to come on video with me. I'll introduce myself. First, I'm Dr. Marnie Peterson, and I am the outreach coordinator for CIDRAP's Antimicrobial Stewardship Project and AMR Project. And I'll be your host and moderator today. First person I'd like to introduce is Dr. Vikas Gupta, SFRMD lead author of the Cancer Medicine and the Lancet Oncology publications. And he's actually going to spend the first 10 minutes with us reviewing that data. So you all have the context of what we're discussing in their important findings. He's the Senior Director of Clinical Affairs at Q-Linea. He's a clinical pharmacist with experience in inpatient care, developing and implementing clinical programs in academic and non-academic settings. Our second author that we have today with us is Dr. Yehuda Marte. She's co-author on many publications, but this publication that we'll be discussing, medical oncologist, assistant professor of medicine, and vice chief of diversity, inclusion, and health equity in the Division of Hematology and Oncology at University of Pennsylvania. She's a global health scholar at the Center for Global Health and a senior fellow at the Leonard Davis Institute of Health Economics at Penn. She's an adjunct lecturer at the University of Botswana, which is important because this is where she conducts much of her research related to access to essential medicines for cancer treatment. And we have Dr. Michael Statlin, also a co-author on these publications, clinical director of the Transplant Oncology Infectious Diseases Program at Weill Cornell, and provides infectious diseases supportive care to immunocompromised individuals. His research interests are in epidemiology, diagnosis, and treatment of multi-resistant gram-negative bacterial infections in immunocompromised individuals, and his research is supported by grants from NIAID and industry. He's co-chair of the Breakpoint Working Group of the Clinical and Laboratory Standards Institute Subcommittee on Antimicrobial Susceptibility Testing. And he participates in multiple committees of NIAID Antibacterial Research Leadership Group and serves on the program committee for ASM Micro, the program committee for that conference. And then finally, we have Michael Craig with us from the CDC. He's the director of the CDC's Antimicrobial Resistance Coordination and Strategy Unit. So we're pleased to have you joining us as well. And he focuses on addressing national goals to combat antimicrobial resistance. He collaborates closely with the leadership within the U.S. Department of Health and Human Services to ensure alignment of public health activities related to antimicrobial resistance. So we'll be able to get his perspective and his work related to AMR and how it interfaces with cancer and oncology treatments. The last thing I'll just advance the slide to. As you can see, this is a very esteemed panel. You all are, how can you participate and engage with these speakers? It's through the chat box. So this is a roundtable. We prepared questions, but we want to hear from you. We want to know what questions do you have for these speakers. So please type them into the chat box there that you'll see through the Zoom functionality. And then finally, I have the objectives that we're going to achieve for this webinar on the next slide. Yeah. The understanding the findings of these new publications that will be presented both in the Lancet Oncology and Cancer Medicine on AMR. In cancer, learn about the implications of the new data, potential considerations to the clinical guidelines and patient care pathways based on the findings of these important research projects. Understand opportunities to further the research, to analyze the impact of cancer and AMR on cancer patients, and understand how the CDC is educating on infection prevention, stewardship, and other aspects to reduce the overall burden of AMR. So these are just some of the big goals that we're going to be discussing today and objectives. So with that, I am going to invite Dr. Gupta. We're going to drop these slides and he's going to come on and present some of the slides he's prepared for all of us to review the key findings of these papers. Welcome. Welcome you all.
Okay, thank you so much. It's really an honor to participate with such an esteemed group of panelists, and looking forward to providing overview of the studies that have been published overall as well. So with that, I am making sure that the right screen is showing here within it.
Yes.
Yes, okay, perfect.
It was there. Now I don't have it anymore.
Okay, perfect. So I'm going to spend a few minutes going over the results of the papers and really move forward to the what's really important, I think, is the discussion that we're going to have as a panel as well. So this is two key studies that were published using a large data set, the BD Insights data set from Becton Dickinson. The inpatient study included over 4.6 million inpatient records or admissions, and the outpatient study included over 1.6 million isolates overall. The goal was to really evaluate broad set of gram-negative pathogens as well as gram-positive pathogens, and we evaluated the AMR rates and incidence and proportion used across multiple sources, so blood, urine, respiratory, but also wound, intra-abdominal, and other sources to kind of get an idea what type of signal are we seeing when it comes to AMR in cancer patients versus non-cancer patients. So when you look at the first study that we intentionally published or wanted to publish in cancer journals, oncology journals, instead of infectious disease, to really get the data out to oncology clinicians overall. The first study was published in Cancer Medicine in December of 2024 and focused on hospitalized patients with cancer. And you can see some of the panelists or co-authors, as Dr. Peterson had mentioned as well. So in this study, what we found is we evaluated two metrics. We evaluated proportion, which I think of as more your antibiogram type of data, also by rate or incidence, which is the per thousand admissions. When we look at it by the traditional antibiogram-like metrics or proportion, what we found is that most AMR combinations showed no difference or lower percent non-susceptibility in cancer patients. So you can see in purple here for Pseudomonas as well as Staph aureus that showed lower rates of resistance when evaluated by percent non-susceptible. But there are three key pathogens that showed a higher proportion of resistance, which is multi-drug resistant gram-negative Enterobacterales, extended spectrum beta-lactamase Enterobacterales, as well as vancomycin resistant Enterococcus or VRE. However, when we evaluated this by incidence or per thousand admission, this is where the denominator remains the same and you can kind of get an idea of what that incidence looks like across different resistance types. You can see the highlights here show that most all pathogen AMR combinations showed a higher incidence rate, except for Acinetobacter baumannii. And you can see vancomycin resistance is nearing twofold, and you can see ESBL positive and some of the other gram-negative resistance types are almost 1.5-fold greater in incidence. This slide kind of summarizes this, but provides the incidence rates for these different resistance types across cancer, which you see in the graph as C, and NC or non-cancer as well. And as the previous table had shown, we're seeing about 1.5 to 2 times higher antibiotic resistance rates in cancer patients overall as well. And I just want to highlight some of the notable differences that you see in the color graph, green being blood, You can see orange and yellow as well in hospitalized patients as well. So what we did is we extended this work to look at ambulatory, and there really is very, very scarce data, if any, in outpatient setting as well. So we looked at incidence and prevalence of antibiotic resistance in outpatients with cancer. This was published in Lancet Oncology in the May issue. I want to also highlight there is a comment that was written on antimicrobial resistance, as well as a review on antimicrobial resistance in with hematologic malignancies, a scoping review. Dr. Marte, who's on the panel, was one of the co-authors on the scoping review as well. So when we look at this from an outpatient perspective, what was interesting is that there is a higher proportion of antibiotic resistance seen in patients with cancer, so percent non-susceptible. Except for Acinetobacter baumannii that you see in purple here, but if you look at the orange highlights, you can see significantly higher proportion of resistance. I want to say notably, fluoroquinolone non-susceptible, about a ratio of 1.44. Multi-drug resistance is twofold higher. And extended spectrum cephalosporins or ESBL positive using third generation cephalosporin rates is almost double seen in the outpatient setting. And you can see vancomycin resistance is also over twofold higher. So you're seeing a consistent theme as far as the specific pathogen types that are higher in patients with cancer as well. So kind of honing in a little bit on culture source here, what you're seeing is this is specifically across blood cultures, and what we're seeing is significantly higher non-susceptible resistance for blood. Notably, you can see fluoroquinolone resistance with the first arrow, the top arrow. Almost 20% of blood positive isolates are for gram negatives are resistant to quinolones, and about 17.8% in non-cancer patients. Extended spectrum cephalosporins in cancer patients is almost 17%. Versus about 11.4% in non-cancer patients. And then you can see vancomycin-resistant enterococcus as well, about 30% in blood in cancer patients versus 19.5% in non-cancer patients. What's interesting is the results that we're showing here, and I mentioned the scoping review that was done that Dr. Marte is a co-author, also found consistent results with higher proportionality of extended spectrum beta-lactamases, as well as vancomycin-resistant enterococcus in patients with hematologic malignancies. Here, evaluating the urine source, you can see about 29% of gram negatives that are seen in the urine in cancer patients are resistant to quinolones, and the ESBL rate is about 16% here overall as well. So much higher in general. And we highlight this for quinolones because that's commonly used as an antibiotic that's for prevention of infection in patients with certain types of cancers overall. So to summarize the results of hospital and ambulatory studies that were done, both bacterial gram-negative and gram-positive pathogens evaluated occur more frequently in cancer patients in both the inpatient and ambulatory settings. The AMR incidence is higher in hospitalized patients, but not as evidenced using traditional antibiogram metrics, which is the percent non-susceptible. However, in the outpatient setting, AMR proportion or percent non-susceptible is higher for important resistance types overall. And this is one of the, I think, the largest studies that is evaluated in the outpatient setting, hopefully provides insights to clinicians for that. These combined results can be informative to institutions, antimicrobial stewardship, and diagnostic efforts. And we really encourage others to build upon this work as well. So we're seeing certain signals that are important here, and we encourage others, not just in the U.S., but outside the U.S., to build upon this work. So I'd like to thank you for this. And Dr. Peterson, I'd like to hand it back to you.
Great. Thank you so much. It's a lot of data in those few slides that I hope everyone was able to get a good context of your scope and some of your questions and some of the key findings. So I'd like to invite the panelists back because we're going to begin the roundtable component of this. And I guess since Dr. Gupta, since you just spoke, I was wondering, just the first question that I'm just going to kind of put out to everyone one at a time is you showed some of the key data points. What did you find most interesting or surprising in the result?
That's a great question. And, I think the difference in metrics on the inpatient side, because oftentimes we're using antibiogram data, and that wasn't showing higher levels of resistance except for a couple pathogens, ESBL positive, as well as vancomycin resistant enterococci. And it's interesting because I've talked to several institutions, specifically oncology centers, and they say we don't see a lot of resistance in that population. I think it struck me that the incidence rate is much, much higher in that population, when you look at it from the second metric. So it's just an alternative metric to be able to evaluate where it may not be as evident when you're looking at your antibiogram data overall.
Right. How about Dr. Marte? There are
Yeah,
oncologists as well
yes.
in our group.
Thank you so much for this, for inviting me to join this panel as an oncologist. I think reflecting on my clinical experience, I would say that, the inpatient results were sort of aligned with our hypothesis in that, you do expect the incidence rate to be higher in patients with cancer who are admitted to the hospital because they tend to be sicker, they have more frequent healthcare contact. I think for me, what was really surprising was the magnitude of antimicrobial resistance emerging from the community. And so these are patients that we usually sort of prescribe empiric antibiotics in the outpatient setting and draw cultures in the outpatient setting. And I think the magnitude of resistance that is, within the community setting was pretty striking to me. Things like Mercer accounting for, 30% or more of resistant infections in blood. I think it's really concerning. Same for, I think, Dr. Gupta, you mentioned about fluoroquinolones. We prescribe that pretty frequently for suspected UTIs, prophylactically for other infections. And so having, resistant rates of greater than 20% in urine, almost 20% in blood, I think is really concerning. And so that I think the outpatient setting data was the most surprising for me.
I agree with that as well. Dr. Setlin, we'd like to hear from you, from your perspective.
Sure, thanks. And also very glad to be invited to speak with all of you. It's a really important topic. As far as surprises, well, I first reiterate what Vika said, that it's important to understand, as a patient, you really care about what is my risk of getting infected by an antimicrobial resistant pathogen, not among all the infections, what proportion are resistant. And so I think it was a clever way to look at it as an incidence in addition to just kind of the standard method that you might miss on an antibiogram. But I would also echo Yehuda's comments about outpatients. And remember, for outpatients, we like to give oral antibiotics, right? It's hard to give IV antibiotics as an outpatient. And so some pathogens I think that are really important that were identified that were more common in outpatients were extended spectrum beta-lactamase producing Enterobacterales. So Enterobacterales are our most common causes of gram-negative infections in patients with cancer. And the extended spectrum beta-lactamases that these organisms carry confer resistance to a lot of our typical or empiric antimicrobial agents. And these organisms are also not just resistant to those beta-lactams, but they're often resistant to other drugs we like to use, like fluoroquinolones and trimethoprim sulfamethoxazole. And so what that means is that you can have an outpatient with an infection that you'd like to be able to treat as an outpatient, maybe because they're not quite as sick yet, but you actually have to bring them into the hospital for IV antibiotics because of antibiotic resistance. And, that obviously bringing somebody into the hospital who doesn't need to be in the hospital, wouldn't otherwise need to be in the hospital, is something that we'd want to avoid. So that was a striking pathogen for me.
Yeah, in hearing the presentation, it made me wonder if you had to focus, is the outpatient then driving, obviously, what you just described, some of the inpatient data, and shining a light on the outpatient and the interventions that can happen there. I'm wondering, Michael Craig has joined now, come off mute. From your perspective, from a policy, how are these findings are helpful? And what are some of the key surprises that you
Yeah,
noted?
happy to. And I think I'm gonna, I guess, one first thank Vikas and the other co-authors for it because I think it's great work. And I think I'll take a slightly different tactic on the surprise here. I think the surprise for me is that this is only coming to light now, right? We haven't done these types of analysis previously as robustly as we've done this. I think to a certain extent, there's been a good understanding that cancer's bad, infections are bad, infections in cancer patients are bad, but we haven't delved deeper into it and especially looked at the challenge of antimicrobial resistance in the cancer population. And I think that that's somewhat of a surprise that we're in 2025 and haven't delved as deeply as we should into this area because it's an area that we all know and we all appreciate and quite frankly we need to be doing more in. So I think I think it's a credit to Vikas and the other co-authors for their work in this area to fill this gap in the literature so that we can quantify some of these things. And I think from a policy perspective and what do we do with this, I think it's really, how do we take this information about this increased risk and come up with interventions that protect patients, that provide more tools to clinicians, and that provide more tools to caregivers, given the fact that we see these challenges on the outpatient side, to help protect those patients from these infections, to help protect patients from antimicrobial resistant infections, and to be able to hopefully in time do follow-up studies on this to maybe see these rates going down. Because I think that's what we really need to do when we see these problems as high as they are and the magnitude that they are. How do we come up with good interventions that are designed to address this problem and help this patient population?
Absolutely. Thank you. Yeah, I think to highlight that this is how could it have taken so long, but how important it is that you brought together oncology with infectious diseases. And it makes you also think about in your personal life, there's not one person probably that hasn't been affected by cancer, some family member or friend. And how often do you hear of them becoming infected with something? And is that a resistant pathogen? So this is something that really needs to be brought to the forefront. And then overall use of antibiotics in these types of patients. So the next question is then for Dr. Marte. As the oncologist, what recommendations would you make for patient management with cancer based on your own research, findings from this paper, maybe things you're thinking about for the future?
Yeah, I do think that what the results really underscore is that we have to sort of shift our traditional focus of AMR from the inpatient setting to also include the outpatient setting. I think we do a good job of working with our infectious disease colleagues in the inpatient setting to ensure that, patients are getting appropriate antibiotics or de-escalating or escalating when indicated. I think the outpatient setting is where we need to do more due diligence. And so we do prescribe a lot of empiric antibiotics for patients that we suspect infections for in the outpatient setting. I think we need to go beyond that and make sure we're following up on culture data to make sure that patients are either getting narrow antibiotics when indicated or broadened antibiotics when indicated. I also think that, because oncologists end up being the primary prescribers of antibiotics in the outpatient setting, it's important for us to integrate that into our education of patients as well. I think as cancer patients, you end up being prescribed, 10 different drugs. And so it's natural that patients stop taking antibiotics when they feel better. And so I think part of our education on cancer treatment or just management in general should also focus on, proper antibiotics use. And so taking antibiotics as indicated for the exact duration. And then also really be better stewards of antibiotic usage. I think our patients tend to be sicker. And so we tend to sort of throw the kitchen sink at them in terms of antibiotics. And so really thinking more critically and intentionally about whether antibiotics are indicated in specific settings are important.
A follow-on question is in the introduction, I mentioned your connection and your research with Botswana. Are there differences and actions, or are they actually quite similar?
So I think, I think what concerns me is that as much as these results are alarming, it's probably much worse in low resource settings. And so we do know from sort of the global AMR data that the burden of AMR is higher in low resource settings. And so when we think about the synergy of just having a higher global AMR burden and higher cancer mortality, I think it is likely that these results are even sort of more alarming in that setting. What is lacking is the surveillance and the data. And so, as Dr. Gupta said, these analyses haven't been done in other settings. And so, a lot of our guidelines on how to treat patients with infectious complications who are diagnosed with cancer is really based on data from, IDSA, which is based on North America guidelines. And I assume that the burden of AMR looks different in these settings. And so, I think the burden is probably worse. A lot needs to be done in terms of just primary prevention. So water, sanitation, good hygiene, things like that, I think would go a long way in low resource settings, in addition to the other things that I talked about in high resource settings.
Yeah, surveillance is very important. And obviously those are probably some of your next steps, is trying to get an understanding of the overall burden of AMR in the particular patient population. Before I move on with some of the roundtable questions, Dr. Gupta, I want to ask you just a little bit more granular detail about the studies, just as keep continuing to put these data in context. The overall scope for surveillance, it was 168 healthcare facilities for the inpatient, is what's in the article, roughly.
Right. And, yep, roughly, and similarly about 190, 98 in the outpatient setting overall.
Geographically in the US, was it?
All the census divisions were covered, but obviously it'll be heavier in some and lighter in others. But there were facilities in each of the 9 census divisions overall.
And then a question around the inclusion, not inclusion, exclusion, how you categorize the groups. How did you categorize them? Cancer versus non-cancer, and where you might, someone that was just in general immunocompromised.
Right.
A little bit more detail on how you bucketed.
Absolutely.
Yeah.
Absolutely. And on the inpatient side, so we used a blended definition. So one is because we had pharmacy order data for these facilities, we looked to see if they were prescribed and cancer medication. So we had a group of experts review that and say, are these used for cancer or not? We adapted that from the NIH cancer medication list. So that was one part of it, is were they prescribed a cancer medication in the last 365 days. On the inpatient side, were they admitted to a cancer unit? Was the other definition applied here. If you didn't meet those criteria, then you were considered non-cancer. In the outpatient setting, we use the same definition of prescribed cancer medication in the last 365 days, but also were you admitted to a cancer unit in the last 365 days as well. So kind of use that as a combined to identify patients that were cancer, and those that did not would be identified as non-cancer on both.
So cancer medications plus cancer being admitted to a
Exactly.
unit. In the non-cancer group, were other immunocompromised individuals included?
It would be.
It's interesting, the risk factor of cancer medications drive, because you're talking about a 1.5 to 2-fold increase risk of AMR, especially in the outpatient.
Yeah, and that's a great point because, as we saw from both inpatient and outpatient, Acinetobacter resistance rates were lower in cancer patients. I think that, the non-cancer did include, high severity of illness patients likely, as well as non-cancer immunocompromised in that population as well. And that's partly why, the last bullet I had on the slide is there's more work to be done in this space to identify that and to kind of dig further into this as well. So it's a great point. So.
Yeah, those are just some of the, when you look at the data and listen to the conversation, I think having that understanding of what are we actually talking about? How does this apply to my clinical practice? So then, Dr. Satlin, this is your question. Like, as an infectious disease clinician, can you share your experiences in treating these challenging infections in cancer patients, and how you're utilizing some of this data as well?
Sure. So for background, I my clinical work is caring for patients who have hematologic malignancies and stem cell transplants. And these patients are a subset of patients with cancer, but they're a subset of patients, I'd argue, are at the highest risk of getting bacterial infections due to resistant pathogens, often because they have neutropenia. So they receive very intensive chemotherapy and they can be neutropenic for prolonged periods of time. And just to share, some of the things that we see clinically when I'm seeing these patients. One is that we have certain situations that are horribly traumatic, where we have patients who are neutropenic, who have a fever, and it's important to understand is that the moment somebody develops a fever, they develop sepsis. We don't actually know, A, if they're actually infected, and we certainly don't know what they're infected with. So we have to make decisions just based on antibiogram data, educated guesses, what antibiotics the patients have been on before. And sometimes we are wrong. And when we're wrong and we pick antibiotics that are not effective against the bacteria that's causing an infection or sepsis, particularly in a neutropenic patient with cancer, it can have dramatic consequences. I have had patients who died within 24 to 36 hours, and we picked antibiotics that we thought were, quote, broad, but they were not effective, it turns out, against the pathogen that was causing the infection. And we don't know what somebody's infected with when they get sick. And so those are really dramatic, but really awful situations where we just get the information too late. And I think one of the things that leads to is the importance of continuing to incorporate rapid diagnostics. So we are starting to get some tools where we can identify the causes of the infections a little bit more quickly. And not only the causes, but identify important resistance mechanisms. For example, ESBLs we can now identify from positive blood cultures. We can, but we're still not there yet. So we still don't have tests that tell us immediately what somebody's infected with or whether it's a resistant pathogen. These tests are not necessarily comprehensive. So we still run into these awful situations. The second type of thing that we thankfully we see more commonly, not as, we don't see that situation that commonly, where people actually die because we don't give them the right antibiotics, is we have these infections due to these multi-drug resistant bacteria. And we have challenging situations where we just don't have a lot of options available to treat these patients. We've had to get emergency IND uses for new antibiotics that aren't even approved yet because we see such extensive resistance. And then probably the most common way this antimicrobial resistance impacts my practice is we have patients with infections in the hospital that don't have any oral option. And the patients get better, but they need more treatment because we know they have an abscess or a source that, is hard to intervene upon. And they need, we have to figure out how they're going to get intravenous antibiotics as an outpatient because of resistance, and in particular, resistance to oral options. So, in addition to needing more antibiotics, we also need more antibiotics that we can give orally because those are antibiotics that patients can take as an outpatient. So that, it's sort of a spectrum of the impact of antimicrobial resistance in the patients that I see who are neutropenic, from the most dramatic to probably more common, but still problematic.
How frequently, I have to ask this. So how frequently do you have to stop your oncology therapy or cancer therapy because of it? You've got to focus on the infection.
So I'm sure Dr. Marte could comment on that as well. But yeah, it's a big problem. And when patients are infected, they can't get more chemotherapy, or they can't get, they have to go off schedule. And these regimens, and oncologists could speak better to this than me. These regimens were studied and designed where people get treatments at specific time periods. Well, if somebody develops septic shock due to resistant bacteria, has to go to the intensive care unit, is very slow to recover, has organ damage from that infection. So that's common too, right? When people who develop sepsis, they can have long-term kidney damage, liver damage, and then some treatments that would be optimal are now off the table. So, it's not just the direct effects of people who die from these infections, it's the complications from these infections that really don't allow our advances in cancer therapy to take hold. And I'd appreciate Dr. Marte's
Yeah,
comment
Dr.
on that as
Marte,
well.
please
Yeah,
respond to that
yeah,
question.
I really want to echo that as well. And I think, just from a patient's perspective, it's very frustrating. And so patients get a cancer diagnosis and it totally upends their lives, changes their lives. And then you get admitted to the hospital and you have an infection. And there's a whole team trying to ensure that, either you're septic and trying to get you to a recovery point. But from a patient perspective, it feels like we're doing nothing, right? Because we're not treating their cancer. And so I think the real challenge with antimicrobial resistance is that it really puts a brake on all these amazing therapies that are in the pipeline that are, novel and improving survival. But our ability to deliver safe cancer care really depends on, antibiotics working when they're supposed to work. And so, I think it's a huge problem and it's traumatic for patients and their families when they feel like their loved one is being admitted and every scan shows the cancer growing, but you can't really treat it because, they have an infection that's not being well controlled. And I think for oncologists as well, it's really challenging. And so I completely agree. I think it's beyond just the immediate effects, it's just the sequelae of complications of AMR as well.
Yeah, correct. I think as health providers, professionals, you're completely aware of this. If you've been on the journey with an individual getting treatment, cancer treatment with a cancer diagnosis, you understand the importance of these infections and trying to prevent them from happening. Before I move on with the next question that we've scheduled here, I have to ask Dr. Gupta another question about the data. Was there a risk factor in the outpatient setting? Like how frequently, I keep thinking like, where's the antimicrobial resistant organisms coming from? Was the hospitalization in the last 90 days like a factor in those outpatient individuals?
That's the next lever. It's a great question, first of all. And I think that, we conducted this not knowing what we would see in the outpatient setting. So we were really looking for signals of resistance and, what the levels of resistance. And I think everybody here has commented on ambulatory setting. But that is the next layer of analyses, cancer type, cancer medications, risk factors in the outpatient setting. What I wanted to also highlight is, one of the things, because infection prevention and a lot of the work that's done in infection prevention is on the inpatient side, this kind of highlights the importance of maybe infection prevention practices to kind of talk to patients about that have resistant organisms in the outpatient setting as well, from that standpoint, and maybe also having the notification. So oftentimes in electronic medical record, you'll see, does this patient have a carbapenem resistance previously or ESBL positive? That maybe those type of rules can also be built for the outpatient setting, because given what we're seeing in the discussion that's been happening here as well, because that can also help alert the clinician when they see the patient as to prior resistance from that standpoint as well. But I think your question is a good one, and that is where we encourage further studies to be done in this space as well.
And I think it perfectly tees up, Michael, Craig, if a question for you from the CDC perspective related to surveillance of AMR in cancer patients, how these data will help inform, next steps or guidelines. And then also a little bit about your work at the CDC around the antibiotic threats report. So you've identified some of these pathogens already as being threats to health and cancer oncology treatment successes. Maybe just telling the listeners a little bit about those reports, and this is seeming to align that you've identified the pathogens. And so what are some of those next steps?
Yeah, thank you for that. So, I mean, I think just taking a step back, the threats report that CDC has released and sort of represents what we consider from the US perspective to be the threats to domestically to the United States of the most urgent, serious, or concerning antimicrobial resistant pathogens that we see. So we put out a report that really details the burden of those different pathogens and provide sort of national level estimates on that. And then in between those, we're always updating and providing more pathogen specific updates on different trends for those pathogens in between sort of the larger reports. So I can let everybody know that we're working on the next update to the threats report, that we expect that to come out in 2026. With new national burden estimates for a lot of these pathogens. But I'll also just let you know we've been updating information on some of the pathogens in that report. We just in the past couple months, we've had some notable publications related to carbapenem-resistant Enterobacterialis, CRE, and the changing epidemiology that we see of that in the United States, where we're actually seeing something that is already a very untreatable pathogen. We see more resistant strains of it. The NDM strains in the US actually outcompeting some of the other more treatable strains. So we're actually getting a bug that's even more and more resistant to new and newer antibiotics that are coming to market, which is of course concerning because these are the type of pathogens in the first place that no one wants to get. And certainly when we're talking about subpopulations that are more immune compromised, that are more at risk, we definitely don't want to see those pathogens in infections in those populations because they are going to be, one, more deadly, they're going to be less treatable, and they're just going to be highly problematic, especially in healthcare settings where they can spread more widely as well. So there's a lot that we're continuing to do to see what the epidemiology of some of these pathogens are changing, make sure that clinicians are aware of it, and provide additional data as we can. Longer term, I think with the threats report, we definitely want to see more information added on subpopulations and other groups so that there can be additional analyses there. We certainly welcome the great work that Vikas and company did on this, and from our perspective, more data is better for everybody. So the more people that are looking at these issues, the more people that are looking at the different challenges of antimicrobial resistance across the field, the better we all are to understand what those threats are and how we can best address them.
Yeah, I think it's the reports are so important to bring attention to the certain pathogens, and I think it also helps to drive something that Dr. Satlin said is the availability of having oral antibiotics that can also treat some of these infections. I do have another question around that. And this is maybe Dr. Satlin can respond as well. Is in the outpatient setting, during cancer treatment, there's the practice of using antibiotics for prophylaxis or to prevent an infection from occurring. And Dr. Marte, you as well. In that practice continuing, is that driving any of the resistance? And then my other question would be, how you need a proper stewardship, because if some of these antibiotics become available in oral form and they are in development, that we don't overuse them because they're accessible then. So Dr. Satlin, I'm just wondering about, I'm still thinking about this outpatient and this overall care of patients and preventing infections.
It's a great question. And so certain patient populations with cancer do receive prophylaxis with antibiotics. And probably the two most common examples are using trimethoprim sulfamethoxazole to prevent infections like pneumocystis. We're not trying to prevent a bacterial infection, but there's collateral damage there, right? Because that also has activity against bacteria and may select out for some of the resistance profiles that we see in the outpatients. So again, not even thinking about trying to treat or prevent a bacterial infection, but we're giving this because it's important to prevent pneumocystis in certain types of patients with cancer. We know it's effective, but there are consequences. The second one is using fluoroquinolones. And I think that's why some of the data on a higher prevalence of fluoroquinolone resistance in Enterobacterialis is so important. And it really extends from the outpatient setting to the inpatient setting. And one of the things that we've seen with our own research is that patients who carry fluoroquinolone resistant enterics in their gut, starting out as an outpatient, coming to an inpatient setting, the fluoroquinolone prophylaxis doesn't work very well. So if you carry those organisms in our gut, we don't typically, it's not common practice for everyone to screen for carriage of those organisms. But what we've learned is that people get infected with what they carry in their gut. And many people do carry these bacteria, and those are the ones who end up developing gram-negative infections despite fluoroquinolone prophylaxis. So I think the implications of that are, not only, of course, do we want to be good stewards of antibiotics. I'm not saying that we shouldn't give prophylaxis, but perhaps we should rethink how we give prophylaxis and think about individualizing it for the patient and perhaps looking to see what patients are colonized with to help us make some of those decisions.
And if I could just add to that, I mean, totally agree and appreciate the comments there, especially on the stewardship and the thoughtfulness that we take in terms of our prescribing wherever it's happening. I think the other thing that I guess I would just like to build on the last comment there related to colonization is I think that's an area that we really need to explore more of. We know that a lot of patients, you don't have to be a cancer patient. Any person, healthy or otherwise, can be colonized. So that means that they have one of these germs, a resistant germ that could be living on their skin, it could be living in their gut, it could be living in their nose. And it's not causing an infection, it's not making them sick, but it is a potential route for transmission. And it does lead to an increased risk of them either transmitting it to someone who could get sick because they're immune compromised, or if they become immune compromised themselves in some way, they could get sick. And so I think highlighting that is an important one because I think where we really need to be going longer term is we need to be seeing how we can develop new modalities for pathogen reduction. How can we eliminate that colonization and get rid of it? And I'm not talking about new antibiotics. I'm talking about things that actually will eliminate that pathogen reduction without essentially the perturbation of the microbiome that an antibiotic would lead to. So might be antibiotic alternatives, they might be phage, they might be a whole variety of things. But I think if we can, get some of those products to market that can reduce that burden, and we've seen some of these applied, chlorhexidine bathing in certain circumstances, mupirocin in the nose. We have some products that can do this on a very basic level for gram-positive pathogens, but we really would love to be able to see some of these things for gram-negative pathogens, for fungal pathogens, so that we can decolonize these patients in a more effective way. And ultimately, I think that could protect them in ways that we're not able to do. And I think that that could also protect them from continually being on antibiotics, which then increases their risk of potentially getting a resistant infection in the future or during their course of treatment.
Yeah, absolutely. Perfect, because I want to talk about some of the infection prevention strategies that are critical to, like you say, just basically reducing the pathogen burden here in this space and other alternatives. Dr. Marte, do you want to talk a little bit about, especially in these vulnerable populations, what are some of the things you're considering or are doing in your practice?
Yeah, so I just sort of wanted to add a little bit to the earlier conversation to say that, I think as an oncologist, the prophylactic antibiotics that we prescribed are based on consensus guidelines. So I think while we're thinking about all of these, it's important to really think about how often we update these guidelines. And so I think the last guidelines from the Infectious Disease Society was from 2018. And as has been highlighted by this data and other trends from the CDC report threads, is that this landscape is changing faster than we're updating guidelines. And so I think it's important to really think about how often these guidelines are updated so that we're really prescribing prophylactic antibiotics for the patients most at risk and not really contributing to the AMR problem. I think with regards to, infection practices, yeah, I think we do a good job in the inpatient setting. There are a lot of guardrails in trying to ensure that providers are aware of contact precautions based on different resistant organisms that patients have. I think we need to extend this into the outpatient setting. And so really educating patients on basic hand hygiene in low resource settings, thinking about clean water access is important. I do think that vaccination is critical for our population. And so in low resource settings, I think it's probably, the highest return on investment is ensuring that there is mass vaccination of the population. And then for cancer patients, thinking about boosters when they're indicated, I think are important as well.
Very, very important for in prevention. Dr. Statlin, what are some of the infection prevention considerations in your practice or things that you're thinking about implementing?
Yeah, so I mean, I think Dr. Marte mentioned some of the, classic infection prevention strategies that we use that, typically will not necessarily guided towards AMR pathogens, but sort of all, bacterial pathogens, including following proper, isolation precautions, et cetera. maybe to shift it a little bit, maybe to back to what Michael was talking about, is one of the things I think about a lot is how to prevent colonized patients from getting infected. What are the strategies that we could use? And maybe I'll highlight two different strategies that are being explored. And Michael mentioned phage therapy, and we're actually doing a clinical trial with an industry partner that's developed a bacteriophage, a cocktail that's specific to E. coli. So why is E. coli important? Well, E. coli is the most common cause of gram-negative bacteremia in oncology patients. And the attractiveness about the phage is that it only targets the pathogen. It only targets E. coli. It doesn't kill healthy bacteria. It doesn't know how to get into human cells, so toxicity should be pretty minimal. It just kills the pathogen. And that's a lot more attractive probably than just giving an alternate antibiotic that, yes, may get rid of the pathogen, at least temporarily. Oh, sorry about that. But also harms the good bacteria, which we know are healthy. So that's one approach, and we're pretty early on with that research, but we have started a clinical trial in patients who are undergoing allogeneic stem cell transplantation. So these are patients who are probably at highest risk of developing bacteremia from what they're colonized with. And a second approach that I think we need more research on is to actually give microbes that prevent the pathogen, really outcompete the pathogen. So you may have a resistant E. coli in your gut, but if you give a bunch of healthy bacteria that can sort of make an environment where the E. coli doesn't really want to proliferate, that could be another option. And there are some companies, including one called Ceres, who had a very exciting result in a preliminary trial that showed that by giving a consortium of healthy microbes, that you may be able to prevent bacterial infections from resistant pathogens. I'll say that these are all really early, though, in this kind of stage of research, and so we need a lot more work to figure out how to do this. But that's something I think about that's very exciting.
Yeah, it is very exciting. I think the research is emerging. One thing I noticed it was at ID Week this past fall is the intersection between stewardship and infection prevention as it pertains to some of the gram-positive screening for nasal decolonization. So the approach, Michael, that you brought up is like, okay, that's working. That seems to be reducing the use of antibiotics as well. So there's some of the stewardship overlays. Where can we focus for gram negatives? And then where would we target what type of technology? So I think this is, I'm sure there'll be more data. You go to the conference in 1 year. I hope there will be more data on this because I think the impact could be very significant. Dr. Marte, I want to ask you about the guidelines. What do you think you would like them updated? Maybe a little bit more frequency. What are some of the barriers to updating them, do you feel?
So I'm not actually sure I'm the best person to
Okay.
So the guidelines for infection prevention are usually led by infectious disease societies with some input from oncology. And so, I'd like to say maybe the frequency with which we have in this sort of robust data probably limits how quickly we can update it. But this is not
The
an area that I'm
collaboration
actively exactly. I think the collaboration definitely helps,
should
but
increase.
I don't know how often we get in the input to actually make informed decisions about guideline changes, and
Yeah.
not really within my.
Just to have data, do the data and have the research conducted and then get it published is its own journey. So yeah, the guidelines are then based on the evidence. So it does take time to get that information.
Yeah, I agree with that, but I do, I think the oncology landscape is very dynamic. We have new therapies being approved by the FDA, constantly. And so those guidelines it still takes evidence and it still takes the clinical trial. So I think the input is dynamic, but the guidelines do get updated often. And so I don't want to say the process of research development is the barrier per se, because we do have, frequent updates to oncology guidelines. I don't know if it's not an adequate answer, but I
No,
do
it's okay.
think
It was a
it
question.
needs to be more frequent than every
Yeah.
2018. That's a little bit old for our current times.
Before I get to the last question, I know we're coming up on the last 5 minutes. Michael, you brought up fungal infections as well and their importance. And I was wondering if Vikas could give us a little bit of insights. It's not, I didn't see it published around fungal infections and what you might have noticed in their overall resistance. Is that data you're thinking about collecting? Are you noticing it in the outpatient? It was a
We,
question I wanted to ask from after reading the manuscripts.
yeah. It's a great question. I think where we focus right now is on the inpatient setting. I think it's intuitively known, but to quantify and what type of pathogens, hopefully we can extend that to the outpatient setting as well. But the primary focus is in the inpatient setting, and then culture specific, because there's a strength to the papers, but there's also a limitation of what we did as well. We didn't dive into pathogen specific, gram negatives and culture source specific as well. So that's where we're looking to kind of extend some of the work, and really encourage others to build upon that as well. So it's a great question, but right now, outpatient setting, we're not able to evaluate at this time for
Okay,
fungal pathogens.
for fungal, but certainly is part of your discussions, I would think, at some point in the future, as we think towards the future. So the last, I guess that's the last question then coming up. I'll just go in order on my screen here. Dr. Statlin, what actions would you like to see next?
So I'm reflecting on Dr. Marte's comments about, why haven't the guidelines been updated in 7 years? And I think part of the problem is that we don't invest in research related to antimicrobial resistance the way that we invest in research related to oncology therapies. And as Michael mentioned, why did it take 20 years for Vikas and his colleagues, to do this study? And I think we need to really focus. I think one of the things that changes guidelines are data. And we really need to, I think a study like this highlights what can be done. And that if we commit resources to better understanding the epidemiology, to developing better diagnostic tests, and to actually do randomized trials, as is so common in oncology, to figure out what the best strategies are, and not just to get antibiotics approved, which is important, but how to use those antibiotics. What are other things that we can do to try to prevent these antimicrobial resistant infections in our patient? And I think the more that we can invest in doing this type of cutting edge research, the more quickly we'll be able to not just update the guidelines, but improve the guidelines for our patients to try to prevent these infections.
Yeah, great response. Michael Craig, you're next on my list. What
Yeah,
do you want to see next?
absolutely. And I would just build on the new tools. I think, we need to be able to identify the colonization of these pathogens, and that colonization could be in the human microbiome. It also could be in the environment. And we need to be able to, once we've identified it, be able to eliminate it effectively and safely for those patients and from the environment. And I really do think that those are tools, along with what we do with regular infection prevention, that will have a giant leap forward in protecting patients from these challenges. Because if we can take contact precautions, if we can take strong hand washing and better patient education and combine it with a decolonizing agent or a pathogen reduction tool, I think that we are going to be able to, one, better address antimicrobial resistance writ large, whether we're talking about inpatient or outpatient settings. And two, we're going to definitely be able to better protect and target and tailor that protection to these cancer patients or other patient populations that are immune compromised and that are particularly susceptible to these infections.
Dr. Marte.
Yeah, I wanted to just sort of make a pitch for the 2024 UN high-level meeting on AMR. I think it generated really renewed focus on AMR beyond just infectious diseases and across multiple vulnerable populations. And so I think, if we can really commit to achieving the goals set out by that UN high-level meeting and ensure that that initial 100 million, commitment towards research and development and other aspects of AMR are actually translated into progress, I think we'll make huge strides. I think in between sort of these UN high-level meetings, there isn't a lot that happens in terms of progress and action. And so I think if we can translate all of those into progress, I think we'll make huge strides in terms of mitigating AMR.
Yeah, that's a very good point. The global initiatives and the actions outlined, but starting to make traction towards these inroads. Dr. Gupta, you're the last.
Yeah, I'm going to piggyback on all these. I think one aspect is we wanted to publish these results in cancer journals or oncology journals. So I think engaging the oncology community, you see Dr. Marte is a co-author and we have other oncologists on there. I think that's one aspect that we need to do a better job is engage the oncology community and advocate collectively within that. And then second part is, Marnie, you asked some great questions, right? About what did you look at this? Did you look at that? Our hope is that these results kind of create other researchers, whether it's in other countries or health systems outside or inside the US, to explore this further. I think, echoing what's been said here, having more evidence is going to help the guidelines aspect of it, but there may be country specific, region specific, et cetera, along that line. So those are two things that I'd like to see happen overall as well.
Yeah, excellent. I look forward to the next presentations and the next posters and research that is generated from these key pivotal studies. I want to thank you all. We're out of time. And I want to thank you all for your time today, your efforts, your research that's driving these changes in practice, and Michael Craig, your efforts at the government level for continuing to push some of these new innovations and agendas forward. The team, Elise Holmes from the CIDRAP team as well for producing the webinar. And just to remind everyone that it's been recorded and we will be posting this to our CIDRAP website. And continue to share with your colleagues and friends about World Antibiotic Awareness Week this week. And thank you all and have a great weekend.
Thank you.
Thank you so much.
Thanks. Bye-bye.